So today we are very lucky to have Dr. Samarasena, who is faculty at UC Irvine, who's going to be presenting on artificial intelligence innovations in gastroenterology. It's a little bit difficult to present Dr. Samarasena. His resume exceeds 40 pages, so that's always a little bit hard to digest, but also it's also difficult as he's going to be my boss in just a few months. However, to sum up, I'd like to talk about Dr. Samarasena. He is a board-certified interventional gastroenterologist that specializes in treatment of a variety of GI disorders. He received his medical degree from Memorial University in Newfoundland, Canada, where he graduated on the Dean's List. He completed both general GI and interventional endoscopy fellowships at UC Irvine. He's an associate professor of medicine in the Division of Gastroenterology and Hepatology. He was recently named within the top 5 physicians in ambulatory surgery group at UC Irvine for his patient satisfaction by Press Ganey for 2 years in a row. He's currently the program director of the UC Irvine Endoscopic Ultrasound and Interventional Endoscopy Fellowship, and was recently named Teaching Attending of the Year by the UC Irvine GI Fellowship. He is a former president of the Orange County GI Society and is a fellow of the American College of Gastroenterology and the American Gastroenterology Association. He's a co-founder of DocBot, a company that specializes in artificial intelligence solutions for GI. And for that, he is the best candidate that we could have figured out in California to present this for us. So thank you again, Dr. Samarasena, for presenting for us. So at this time, I'll stop sharing. So Dr. Samarasena, you can present your slides.
Great, Mike. Thank you so much for that introduction. And it really is a pleasure to talk about this topic. I mean, this is a new topic, and it's exciting time. And you know, it's right now a pretty small group of us that are kind of working on AI in the GI space. And I learned this because the AGA actually asked me to chair the AGA AI consensus meeting in September. And you know, I was really honored, and you know, I'm looking around for kind of other speakers and other experts. And, you know, it really is a pretty small group right now. So for those fellows that are interested in the content of this presentation, please feel free to reach out to me afterwards. And I would love to talk to and mentor anyone that is willing to sort of walk this journey with me, because it is truly, truly fascinating stuff. And it's only getting better and better. So I have a bunch of disclosures. I'm a consultant and on the advisory board for multiple companies. And you know, the biggest one that Mike mentioned already is myself and my friend and colleague, Bill Carnes, co-founded a company called DocBot about 5 years ago. And things, you know, so a lot of the content in this presentation will be, you know, things that DocBot have worked on, but I'll definitely be talking about other companies and other work in this space also. So, all right, Mike, let's get started. So AI, you know, we have seen this kind of facial recognition software on our phones. You know, a few of you in Northern California may have heard of a company called Tesla, and basically self-driving automobiles also using AI. The airports are using AI to check fingerprints. A lot of facial recognition things coming up in industry. We're all also using AI to find Waldo, apparently. But AI in medicine is sort of a new idea, and AI for GI is also kind of a new concept. But I think you're going to understand by the end of this presentation why GI is so well suited for artificial intelligence technology, probably more so than any other field in medicine, I believe. So we'll start off with what is artificial intelligence, and a lot of presentations start with this definition. So it refers to the ability of a computer to perform a task associated with intelligent beings, including cognitive functions that might mimic the human mind, such as the ability to learn. And I might take that definition just a little bit further and say, also, based on what it's learned, the ability to predict. And that really is, I think, what makes this sort of type of AI that we're talking about so important. you may have you may know that the term AI has been around for a very, very long time, since the 50s, and you've probably heard terms like neural networks and transfer learning and machine learning and deep learning and convolutional neural networks, and you'll probably get a better idea of what all that means by the end of this talk. And if you're looking for more information about how AI can assist gastroenterology, this is actually a really nice review. It was in the Red Journal in 2019, really, really well done review talking about how AI will affect gastroenterology over the next few years. One of the things that we're going to touch on a lot is something called computer vision, and it's a branch of computer science that really leans on AI for augmenting our perception and interpretation of things we perceive visually. And as you can see, a large part of computer vision is embedded in AI. Now, you've probably heard of machine learning, which is basically a subset of artificial intelligence. And really, machine learning is the computer learning by themselves to make predictions. And this learning is almost always supervised learning, but it requires criteria to be provided manually to the computer. Deep learning is sort of a subset of machine learning. It's the next evolution of machine learning, and it can be supervised or unsupervised. And whenever we as humans receive new information, the brain tries to compare it to known information or items we've seen before. And so essentially it's automatically discovering and learning features to be used for classification. And I'm going to start off by sort of giving you an example of machine learning that's non-deep and deep learning as well. So if I was to design an algorithm to look at still images of stuff, and I wanted my algorithm to detect cats, what I would do if I was setting up a non-deep machine learning algorithm is I would come up with a bunch of criteria for what a cat looks like. So in this case, I might say, okay, this object has a couple of ears, it's got some eyes, it's got a little nose, it's got a 2 front legs, and it's got a long tail. And if my algorithm saw this picture of a cat, it would probably do a pretty good job and probably recognize this as being a cat. But if my algorithm saw this picture, it might have a harder time. So that's one of the kind of problems with machine learning that's not deep learning. Now, deep learning is a different approach. It's basically showing the algorithm and showing the computer lots and lots and lots of pictures of cats, lots and lots of pictures of things that are not cats, and then developing and building basically a convolutional neural network. And this is what AI scientists do. There's multiple layers that can be set up by the AI scientists to evaluate and look at this image. So in this particular example, one layer is identifying light and dark pixel values. The next layer is identifying just edges. The next layer is identifying combinations of edges. And the next layer is identifying features. And then the last layer is identifying combinations of features. So the algorithm is looking at sort of different parts, different components at different scales to give you the best prediction. And in this case, it recognizes this set of edges, combinations of edges and features and combination of features as George Washington. And really, that's what an AI scientist does. They set up these feature maps that look at the whole image or parts of the image in a slightly different way so that at the end, you get the most accurate prediction when you get to your output layer of what class this image belongs to. And we've got some superb AI scientists that do this for us. And this is very much like what the human brain does. In fact, that's why it's called neural networks, because they're modeled after the biological nervous systems of animals. So if you think about it, the input layer is the retina. There's layers of neurons in the visual cortex, and there's sets of neurons that detect edges. There's sets of neurons that recognize shapes. There's shapes that lead to the recognition of complex objects. And then you have your object output layer, which is basically where objects are classified and then learned. So here, we've got an algorithm that's able to look at a picture and detect multiple things and classify multiple things. And you can see that this is classifying the dog with pretty good probability, a person, a horse, another person over there in the corner. And it's, identifying or classifying that as a car. But, one of the things I might say is that really a car? To me, it kind of looks like a Chevy pickup truck. And so this is sort of kind of highlighting one of those kind of important kind of things to consider is, how you classify something is so important. And if you need to subclassify something, that will be sort of important. And when you do kind of clinical things, classifying and subclassifying correctly is extremely important. So endoscopy is literally like my favorite thing to do. And it's probably at work, all of your most favorite thing to do. But if you think about endoscopy, it's essentially a bunch of still images. We're just taking pictures with a super, super fast snapping camera, and we're stringing them together in this video clip. And most times, these still images are happening at 30 frames, or sometimes 60 frames per second. But wouldn't it be awesome if we could have a computer analyze those frames for abnormalities, and you've trained it, and then it can predict where the abnormality is and potentially what the abnormality is and classify it for you so you can make a diagnosis. And then after you make that diagnosis, you can think about how you can address that clinical situation with the treatment. And that's sort of one of the reasons why, AI, especially deep learning, computer vision algorithms are so well suited for GI. But image recognition is not always easy. And it was surprising that, the algorithm had a hard time detecting here which one was the muffin, which one was the cookie, and which one was the dog. And for us, we can look at all of these and almost instantly tell you, which is which. But for the algorithm, it was actually quite challenging. And we've seen algorithms, get fooled in other areas as well, such as self-driving cars. So, we have to be careful. And in medicine, it's no different. And really, it comes down to making algorithms the best way and doing them responsibly. And so what makes a good AI model? So one of the things that we've definitely found is you need lots of data. And really, honestly, the people that are going to be most successful with, this AI space is really the people that have lots of data with expert annotations and really, really good classifications, subclassifications. And you can probably, see why that would be the case. One of the things that, we talk about a lot is overfitting. And overfitting is basically where you are training the algorithm on one data set, and that data set is sort of not really that generalizable. So if I was building a Barrett's esophagus algorithm to detect dysplasia, and I only used the data from UC Irvine, and I only used my Olympus scope, then that data or that algorithm may not really be that generalizable to another institution, another patient population, or another scope manufacturer. So using diverse sources is very, very important to make it as generalizable as possible. Also, when you think about a model, you probably need to think about the most important features, the ones that make sense and correlate with clinical importance. So making an algorithm to detect say, diverticulosis in the colon may not be as clinically important as doing an algorithm to detect colon polyps or flat ones and cystic adenomas. And so, making an algorithm detect really big polyps, may not be as important as really focusing on an algorithm that can detect the most subtle ones. The other thing that makes a good AI model is real world practice. And we've definitely learned this. You can even say the hard way. We published these great papers on how well the AI algorithm performs on still images, and then we move to how does the algorithm perform on basically pre-recorded video, and this pre-recorded video, these like perfect videos and just really nice video clips, and the algorithm performs pretty well. And then we put the algorithm in a patient in real time, in real life, and it's so noisy, so messy, and there's just a whole new set of variables that you need to sort of address. So again, what's working well in still images or pre-recorded video may not necessarily work well in real world practice. So as I was saying, I think one of the takeaways from this is, why is AI good for GI right now? Well, we know that we spend more time in front of a TV than any other specialty in medicine. So that's kind of cool. The other thing is, high definition endoscopy is basically everywhere now. And so now this added fidelity and detail has led to richer visual information to help differentiate or classify different disease states. And so this is another sort of nice thing that we're seeing in the technology. Also now, we've got these large classified data sets that are available. And some are, homemade, like all the 300,000 videos that Dr. Carnes annotated himself over the last 10 years. There's and also more video data available because now video recording in endoscopy rooms is becoming much, much more common. The other thing that's sort of helpful is the computing power. Thanks to video game industry, we have high performance graphics processing units or GPUs, and we can actually process 30 or 60 frames per second through an AI algorithm and spit out a prediction in real time. And so sort of the convergence of kind of all these things has made GI really, really primed for AI. So in the next part of the talk, I want to talk about the key focus areas for AI and GI today in 2022. And they are really colonoscopy and colon cancer prevention, documentation assistance and automation, capsule endoscopy, and Barrett's esophagus dysplasia detection. And there's a lot of other things that we're being asked to look at, but these are really the areas that a lot of companies are interested in, probably because commercialization is probably going to be easiest in these areas. So sometimes the motivation for focusing in a specific area may not be the clinical need per se. There may be other clinical problems that we need to address, but these are the ones that people are going after first. So the next few slides are part of a talk I gave for the ASGE. We know that the best way to prevent somebody from getting colon cancer is detection and removal of adenomatous polyps. We know missed polyps are a big issue in colonoscopy, and developing solutions to help improve ADR and PDR are critical in reducing the incidence of colon cancer. AI may be particularly well suited to endoscopic problems. As we mentioned, there's a large volumes, they're image-based, they're patternistic, meaning an adenoma in one patient kind of look very similar to an adenoma in another patient or another patient. So one of the things we know is that endoscopist's ability to detect polyps is affected by fatigue and stress, level of experience, but AI algorithms that can support endoscopists by improving the consistency of polyp detection, it doesn't depend on fatigue, stress, level of experience. It can maintain adequacy of technique despite these factors because the computer never gets tired. So in terms of targets for AI in colonoscopy, there's really 5 things that people are looking at, and they're all very, very cool. Polyp detection. This is the thing that probably most people are familiar with. Using an algorithm to detect polyps, I call these spotters. And these are basically the equivalent to an additional set of eyes watching the screen. It's sort of like when you get your text to watch your screen, and you get your nurse to watch your screen, and everybody's sort of watching at the same time and like pointing things out. And well, this is essentially what the algorithm is doing. And these are usually deep learning convolutional neural network trained algorithms based on training from tons of polyp images in the past. And so, but the actual output, from different companies is different and is, you can say, evolving. So first thing, it was sort of like this non-localizing alert. So, basically, if it saw a polyp, it would just sort of flash a signal on the screen. It wouldn't tell you where the polyp was. It would just tell you there's a polyp here somewhere, endoscopists, please, look for them. And so, so that's sort of the non-localizing alert. In some setups, there's actually 2 screens where, and this is really more of a technological limitation, and one that was actually difficult to overcome for some time, and so this is sort of a second monitor, and you can see it detecting the polyp, and then you do your sort of your primary kind of viewing on the left monitor. And then you could say the most advanced form is a single monitor with box localization. And this is, so this is actually the GI Genius system by Medtronic. And you can see that, it's drawing a really nice box around a polyp that was probably going to be difficult to find. So the question is, does this stuff work? Well, our group did a meta-analysis a couple of years back, looking at some randomized controlled trials, with the primary outcomes being adenoma detection rate and polyp detection rate. And if you look at the numbers of these trials, pretty big numbers, some over 1,000. They're all RCTs, so it's pretty compelling when they're set up this way. And they had different sort of algorithm outputs. Some had that on-screen alert box, some had the a visual alert, and the setups were a little different. Some had like the dual monitor thing, and some had like basically an endoscopist, but then there was an observing endoscopist on a separate monitor, and so sort of interesting study designs in a lot of these cases. But what it found was that all the algorithms really improved adenoma detection and polyp detection, and it actually did a pretty good job with small polyps, less than 5 millimeters. It improved detection of sessile and flat polyps as well. And it improved the detection of lesions in basically all colonic segments except the cecum, based on our analysis. So these spotters, these are systems that are pretty close to being ready for prime time. In fact, there's one currently FDA approved one, that's Medtronic's GI Genius. The data thus far is promising. One of the things that we always worry about is generalizability. A lot of these systems are being created in China, and we wonder if these are going to work as well with the endoscope brands that we have in the US. With these spotters, there is still a variation in procedural setup, and of course, spotting a polyp is only possible if you have a good bowel prep, good technique for mucosal inspection. If you're not exposing that mucosa, these spotters really won't help. If you're not looking behind folds, you're not going to really move the needle in terms of improved ADR. The next target for AI in colonoscopy is what I call performance supervision. And this is basically the AI aiding the endoscopist to perform colonoscopy with a higher quality technique. Now, some people call this policing, but I think it's more of an adjunct or an assistant. And one of the targets for improving performance is withdrawal time. So, we know that this seems like a pretty obvious target for AI development. It's an important indicator of quality in colonoscopy guidelines. And we know that, if you pull back too fast, you're going to decrease stability, increase the risk of not visualizing the mucosa, and you're going to miss polyps. So this is a study looking at a computer-aided system called EndoAngel. And basically, it was able to identify the endoscopist slipping or moving back too quickly based on the previously seen frames. So if the frames looked too dissimilar from one another over a period of time, they were probably going too fast. So essentially, this ended up being kind of like a speedometer of withdrawal. So with the EndoAngel system on, withdrawal times were higher, as you might expect, but then ADRs also were higher. The polyp detection rate was higher, and even in detecting large polyps, and improvement appeared to be predominantly higher in sigmoid and transverse colon. So this is another study looking at sort of a combination of AI modalities to improve quality. And they call this the AQCS, Automatic Quality Control System. And this had a bunch of algorithms together. So one algorithm detected the beginning and the end of withdrawal phase. They could kind of recognize blurry frames and consecutive frame similarity for that speedometer function. They actually had an algorithm that assessed mucosal visibility, and then they also had sort of a colon polyp spotter. And so the output was basically an automated procedural timer, an audio prompt for rapid withdrawal speed or instability, audio prompt for Boston bowel preparation score less than 2, as well as a polyp detection bounding box. So a whole bunch of stuff. And as you can kind of predict, the withdrawal time was significantly longer. There was improved adequate bowel preparation rates in those that use this system. There was an improved ADR, pretty significant improvement actually. And detection rates in all colonic segments got better except cecum and rectum, and improved detection of both flat and sessile adenomas. So, this is, I think, pretty cool stuff. I mean, I think this will potentially help somebody who's maybe not the most technically excellent colonoscopist do things in a way that may slow them down, but will probably improve the quality of their exams. Another neat thing that a friend of mine is working on is mucosal surface area tracking. And, as I mentioned, one of the main reasons why you're going to miss a polyp is it wasn't present in the field of view because you didn't really look at the whole mucosal surface. You didn't look behind the folds. And so this is a cool algorithm that assesses, how much of the mucosal surface you're actually looking at. So I'm here at sort of top left, top right, bottom left, bottom right, and you kind of play this game where you're trying to turn all of these things green. So here you can see, the bottom left, you haven't really looked well in this segment of the colon at the bottom left side of the screen. And so you're basically going to try and work and look better at the bottom left to get that as green as possible and increase your score. In the meantime, on withdrawal, it's assessing the clarity, the preparation, the distension. And so at the end of the study, you get essentially this fingerprint that's kind of quantifying how well you did with the mucosal exam. And so this, is almost like a video game now. You're trying to kind of create the score on this game. And essentially the byproduct of that, or the side effect of that, is you're basically pushing the endoscopist to inspect more carefully. So interesting stuff. The other area of interest in colon is definitely optical histopathology. About 7 years back, the ASGE put forth what we call the PIVI criteria for histology of diminutive colorectal polyps. Basically, these PIVI thresholds are saying that if an optical technology can achieve these thresholds, then we probably don't have to take biopsies anymore. So if you have a 90% greater negative predictive value for adenomatous histology based on your in vivo optical diagnosis technology, you probably don't have to send it to the pathologist. And so where this, is helpful is, for example, the concept of resect and discard. If you identify a polyp as a small adenoma, it's less than 10 millimeters in size, then you can say, okay, that's or less than 5 millimeters in size, you can say that's an adenoma. I'm going to take it out. I'm going to put it in the trash. I'm not going to send it to the pathologist, but I'm going to call that adenoma number 1. And the other concept is diagnose and leave behind, which is if you see a hyperplastic polyp in the rectal sigmoid, and optical technology says it is hyperplastic, you can just diagnose that as a hyperplastic polyp and leave it behind. So how does AI do for this now? And this is more, I guess, maybe a little bit more of a challenge than detecting a polyp. Now you're basically looking at a polyp and you're assessing the histology based on the mucosal and vascular pattern. Well, this is a meta-analysis of 18 studies. Most were retrospective. They're not real time. A lot of them were on images. Really, AI did a very good job. It's actually did a much better job than the endoscopists in predicting histology. And a lot of these were with narrowband imaging. And so, the benefits, again, are resect and discard, diagnose and leave behind. But one of the things that, I sort of bring up is really this was minimal data. There's really minimal data on real-time prospective studies looking at this in real time. And I think, that needs to be seen before we say we should, start doing this on our colonoscopies. Now, I know you are mostly GI fellows, but it doesn't take long to get sick of writing procedure notes. And this is, I think, something that we are all excited about. For those of us that do kind of high volume endoscopy, is having the AI write our note for us. So essentially, an AI algorithm is watching the colonoscopy procedure, it's taking notes, and it's reporting. And this has the potential to avoid errors, improve efficiency, minimize clicks and screen time, miles, and really the main thing is it gets us home a little bit quicker. So Dr. Carnes and DocBot has been very busy trying to make this a reality. It requires multiple algorithms to be running simultaneously. You need a polyp detection algorithm, you need an optical path algorithm, you need a landmark recognition algorithm, you need a prep quantification algorithm, you need an algorithm that can detect your tools that you're using, and then you need an algorithm that can detect polyp size and morphology as well. And if you can throw this all together into a box, and then you can potentially get this sort of reality. So this is a DocBot prototype. So the AI sort of detects your in and out time. It figures out when you're at the cecum, so it calculates your insertion time. Then the polyp detection algorithm is detecting your polyp, and it's also predicting the pathology of the polyp as well. It's also detecting which tool you're about to use, and it's also detecting bowel preparation. And now the latest iterations of the algorithms can do kind of multiple polyps at one time. It tells you, it figures out when you're outside of the colon, so it can calculate your withdrawal time, basically with and without interventions. And I think we're getting there. So to conclude this section of the talk, I really believe that an AI-assisted colonoscopy is coming to you soon. We've got, you can imagine an AI has assisted you in performing a detailed exam with that polyp spotter technology, withdrawal speedometer, maybe a mucosal surface mapping tool. AI has recorded all the quality metrics, cecal intubation, withdrawal time, prep quality, calculated ADR, using the optical path AI. The AI completes your colonoscopy reports. You auto-label the images. It auto-labels the images, including the cecum, puts in your diagnostic and procedure codes, potentially gives you surveillance recommendations. Simply review it, edit it, and sign it. And then the AI is continuously learning as well to make this, better and better. So I think, with the way things are heading, this is going to be a reality, I believe, the next few years. So kind of moving right along, really just want to quickly touch on capsule endoscopy. This is basically as exciting as capsule endoscopy reading gets. You're in a room by yourself while everybody's like having fun doing something else. And, is there any role for AI? And Dr. Carnes has worked on an algorithm looking at 53,000 frames of small bowel capsule studies, and looking at landmark recognition, understanding if you're in the esophagus, in the stomach, in the small bowel, or in the colon, but then also looking at abnormalities. And so based on this study, the algorithm was able to very accurately understand where it was in the which organ it was seeing, but also did a very, very good job in detecting abnormalities. And if you basically just focus on the frames with any type or suggestion of an abnormality, and you remove all the normal frames that have been classified as normal by the algorithm, you will, in this study, reduce your capsule reading time anywhere from 30 to 50%. So I think, there is potentially a role for AI when it comes to capsule endoscopy. The last section I want to talk on is my sort of baby, a project I'm very passionate about regarding Barrett's esophagus. And so we all know what Barrett's is. It's where in the normal stratified squamous epithelium of the esophagus is replaced by the salmon-colored tissue that is metaplastic and has become intestinalized. Anybody with a segment of Barrett should undergo surveillance with endoscopy. And right now, our guidelines suggest using something called Seattle protocol, which is taking 4 quadrant biopsies every 2 centimeters for non-dysplastic and every 1 centimeter for dysplastic. There's a ton of problems with Seattle protocol, the biggest of which it doesn't really work to protect patients against esophageal cancer. And unfortunately, esophageal cancer and high-grade dysplasia is on the rise. And so again, ASG has put forth PIVI criteria. So if an optical technology can reach a per patient sensitivity of 90%, a negative predictive value of 98%, and specificity of 80% for detecting early esophageal neoplasia, then potentially we can do away with Seattle protocol biopsies. And a lot of technologies have tried to achieve these PIVI threshold. Chromoendoscopy with acetic acid, virtual chromoendoscopy with narrowband imaging, magnification endoscopy and endocytoscopy, which they have in Japan, confocal laser endomicroscopy with the Cellvizio system. And there was a technology around for a long time called the 9-point system that leaned on optical coherence tomography. And then, fast forward a few years after the PIVI thresholds were set, the ASG looked at these technologies to see if any of these actually met the PIVI thresholds based on the literature. And it looked like acetic acid and narrowband imaging were the only two that met the PV thresholds. But the caveat was these were really experts that could perform at this level. So so in Barrett's and dysplasia detection, what really constitutes an expert? Well, you probably don't need to be an expert to know that this is abnormal on the left side of the esophagus versus the right side, but you probably have to be more of an expert to know that, to detect these, and these are two examples of early esophageal cancer. This is one of my cases. You can probably look carefully and hopefully see the early esophageal cancer here. Well, this one might be more difficult. This is an early esophageal cancer. And, it's, and this is a patient that I was asked to do an endoscopic ultrasound on. I heard he had Barrett's. So I said, well, let me put down the regular camera and saw this. And so essentially this whole area here is an early esophageal cancer. So, Barrett's is a tough one. I don't think dysplasia detection is as easy as finding colon polyps, but I think that's even more of a reason to build an algorithm that can help endoscopists do this better. Because we know that we can do this with colon polyps, but the question is, can we do this with Barrett's neoplasia? And so I did a study a couple of years back with still images to see if an algorithm could detect things detect neoplasia well on still images. This was in GIE. And I wanted to actually spend a few minutes just talking about the process of creating an algorithm and sort of how it works. Because I think you'll get a flavor for how we do this. So basically, whenever we come up with a project, we always need to have an aim. And so in this case, the aim was to assess if a convolutional neural network can aid in the recognition of early esophageal neoplasia and Barrett's. And so then we need a strategy for how the algorithm would be set up. And so in this algorithm, the first step was to see if the computer could do a binary classification. Is there dysplasia on this image, or is there no dysplasia on this image? It's not going to tell us where it is. It's just going to tell us, is there dysplasia or is there no dysplasia? The second step is going to be localization. So it's going to basically, hopefully, put a bounding box over the area where the dysplasia is. So for the binary classification, we use one type of architecture called exception. For the object detection part, we use another architecture called YOLO. So then we basically train it with images. So we use 916 images from 70 patients retrospectively collected with histology proven esophageal neoplasia, basically high-grade dysplasia or early cancer. These were all images from the Olympus system. We had two experts that were using annotating technology to mask the areas of dysplasia. And then we used 916 control images of Barrett's without dysplasia. And so here's a glimpse at the kind of annotation software, and we're kind of drawing boxes on all these frames of video or images, showing kind of the algorithm, what dysplasia looks like. So then you have to build a convolutional neural network, and it's this was built on TensorFlow and pre-trained on something called ImageNet, which is basically a standardized set of images published for AI scientists. But the other thing we did was we pre-trained it also on a whole bunch of colon images and endoscopy images of all sorts. And I think that's helpful, as opposed to like boats and trees and other stuff. We're training it on things sort of within the kind of endoscopy realm. One of the things that's commonly done in AI algorithm development is this sort of internal validation called a cross-validation. And so if you're doing a fourfold cross-validation, you'll basically take all of your images and you'll partition them into training and validation. So for example, a fourfold cross validation does 75% of the images belong to the training bucket, and then 25 are excluded from the training. And then you basically test how well the algorithm does on that validation set. And then after you've done that, you kind of get some data, and then you just sort of put everything back together again. And then you pick out another 25%, a different 25%, and then the other 75% become the training set. And you do that 4 times. And so that's a common thing you might see in papers on AI algorithm development. So for the localization part, we had to predefine something called intersection over union, which is essentially this. So if the prediction is here and the lesion is over here, then this is, this much intersection, and union is here. So for example, here, if the prediction is right, really exactly where the horse is, then the intersection over union is 1.0. So then we had to ask, the clinicians, okay, clinicians, what do you think is a good enough intersection over union that you think this is going to be helpful as a clinical tool? And, does it have to be this tight, to the lesion for it to be helpful? Or could we, relax it a little bit? Could we relax it, as much as 0.4, 0.3? So we actually, polled endoscopists, and we found that actually 0.3 was totally fine. If we were sort of, this far off during a real-time video, it was still clinically helpful. And because this is predicting 30 frames per second, it's sort of hovering over areas, and so this was definitely adequate. So these were sort of like examples of intersection over union. So if the green box was the prediction, the red box was the expert annotation, this was still clinically helpful. One of the things that's a little bit different with AI algorithm statistics is you can't really use true negatives because the number of true negatives is so heavily biased in these studies. You can't use things like sensitivity, specificity, or accuracy. You have to use a metric called mean average precision that doesn't rely so much on true negatives. And so some of the statistics with these studies are a little bit, foreign to us because we're used to these other types of kind of biostats. And so that was sort of interesting and to learn about. So this would be an example of detection. So this is the expert annotation, and this is what the algorithm said was where the dysplasia was. So, and this met a threshold of an intersection of union greater than 0.3. So this was a true positive. So after the training, we basically showed it a bunch of images, and overall, it did very well for the binary classification, and for the localization, the mean average precision was actually very, very good. The neat thing about this algorithm is it can run very quickly, and the benefit of that, and I'm going to speed up here because we're running out of time, is you can put the algorithm into a scope, and you can turn it on, and you can get real-time predictions. And this was one of the most important things to me, was that we're going to basically not have to pause the image in order to have the algorithm make a prediction. So I've shown this video to people who don't see the box, and I asked them, where is the dysplasia in this video? And they look at this stuff and like, I'm not sure if it's, I'm not sure I've seen it yet. And but in reality, for those who see a lot of Barretts, this is all dysplastic. That entire section that we're seeing right now is all dysplastic, and the algorithm is sort of going nuts. And so so this I pitched this at the AGA Tech Summit. I was one of the Shark Tank contestants at that summit, and there was an FDA representative on the panel, and we pitched and we showed them this, and his first comment was, "This is an excellent idea," and so I was really encouraged by that, and so we applied for kind of FDA. We put an FDA application. We actually got a breakthrough device designation for this, so we're really busy working on this now to see if we can get it there. And one of the things that we most recently did was we took some video clips from Vani Kanda and Arvind Trindad, who are really big into Barrett's, and we just let the algorithm run on those clips, and it actually did a really nice job. So exciting stuff. Things are looking good. It needs more training, and we're busy sort of doing that. But hopefully, this is something that we'll see in the scope in the not too distant future. And the last, it all sounds really great, I know, but I want to just highlight a few kind of the pitfalls with AI research. I think I mentioned a little bit about overfitting, where it's you're training the model to be too attuned to data on which it was trained, and it's not really as applicable to another data set. One of the common mistakes is sometimes not adequately separating the training set from the test set, and that can lead to something called data leakage. Also mentioned lack of diversity in the data set. It's important, an ideal would be the training data set encompasses every possible lesion, every possible version of a lesion, every possible imaging feature that one would encounter in clinical practice. And that's really, not that feasible. And, I get the CEO of the company always asking me, "So Jason, how many more images, do we need to train it with?" And this algorithm, and it's really sometimes not about the number of images, it's about the diversity of the images. One of the things that we see is companies doing things that lead to prediction speeds that are too slow for real time. If you're not spitting out predictions at 45 or 30 frames per second, then you're not going to be able to use this real time, and you're going to have to freeze an image in order to get a prediction, which I don't think is very useful for the clinician. The other thing we touched on a little bit was external validation. So that was really the reason why I had images and videos sent from two completely different sites using completely different scopes to see if the algorithm worked well in a group outside of UCI. One of the things that I get asked now is by companies to say, "Hey, Jason, can you make an AI algorithm for this? And how would that look?" And then the first question I ask is, "Well, what's the ground truth?" And so one of the endomicroscopy companies approached me about making an AI algorithm for endomicroscopy. And the problem is you don't have any pathology in a lot of cases. You're basically leaving the ground truth up to the expert. So then your algorithm then, if it's being trained by an expert and the ground truth is the expert, it's only going to be as good as the expert's opinion on what they're saying. And that's sometimes very suboptimal. So Mike, sorry, this is my last slide, and I know I'm cutting into the Q&A time, but I think we're really seeing continuous iterative enhancements with these algorithms. We've got real-time processing speeds and predictions because of the advancement in computing hardware. There's really a ton of excitement from researchers, industry, even government and regulatory firms to implement AI technology into medical devices. I can pretty much guarantee to you that there's going to be computer-assisted detection and computer-assisted diagnosis algorithm integration into the endoscope very, very soon. So I think AI is here and it's changing our world. and it's even going to change endoscopy. And so let's embrace it, and let's do it responsibly. And with that, I thank you for your attention.
All right, great. Thank you so much, Dr. Samarasena. Yeah, this was a great presentation. I learned a lot. And so I think that's the same for a lot of our audience as well. I think one of the questions that was posed in the chat box is AI in cars ultimately has the goal of self-driving cars so that the driver can do other tasks. So what do you envision the field of AI and GI will become in, say, 20 to 30 years? Will we have GI assistants withdrawing and GI physicians are running back and forth between different rooms and performing the polypectomies?
Yeah, so one of the things that gets lumped into AI is robotics, and I think they're sort of different things, but the merger of artificial intelligence and robotic technology, it's inevitable. If you've got a robotic endoscope that can visualize where it needs to go, it's detecting where the folds converge, where the lumen is. That's, you could say, kind of all sort of potentially like computer vision algorithms that are allowing it to do that. So one of the companies I'm consulting for is building an endoscopic robot, and so there's talks of, well, once the robot gets to the end, and it still needs to withdraw, it still needs to look for these things. So why not have, these colonoscopy polyp detection algorithms, all these algorithms that are being used for human? Why can't it be used for the robot as well? And there's no reason why it can't. So, but I think, with robotic technology, we are still a ways away. One of the things I feel a lot of companies are missing is that colonoscopy is actually, you actually have to move your hands in a very quick way to counteract peristalsis, and you have to kind of react very, very quickly. You don't realize you're doing it, and you almost have to beat the peristalsis, and the rhythm of the procedure and the rhythm of your kind of your endoscopy needs to be sort of at a higher pace than the peristalsis, the movement of the colon. And I think a lot of the robots that I've seen are just too slow. I think they'll catch up, but I think 20 years down the road, I see, as long as the cost is not too exorbitant, there's definitely going to be I think that technology around. But the other way that people are looking at it is, well, do I need a GI doctor, to do a high quality colonoscopy? And if you look at the studies in advanced practice providers in other countries that are doing colonoscopies, their outcomes in Canada and in England, have been superb. But if you had APPs doing colonoscopy, they haven't done a full fellowship, but then they've got an AI kind of algorithm on their scope that's sort of assisting them to maybe not miss even more, or maybe coaching them to do it even better. And then you've got this sort of fingerprint of how they did after each colonoscopy. You can sort of understand how a health system would find that appealing, because from a cost standpoint, that could be cost effective.
Great. We probably have time for just about one more question, I think. So the final question is, has there been any pushback against using AI in colonoscopies because it takes longer, especially in practice settings where the primary goal is getting a lot of scopes done and not necessarily improving ADR?
Yeah, I know exactly. So, I was talking to a good friend of mine who's in Spain, and he's an interventional endoscopist, and he's like, Jason, what are you doing all this AI stuff for? It's like, shouldn't you be like, figuring out how to, measure portal pressures and figure out how we can do ERCP better, and you're really on this AI kick. And I was like, yeah, it's so cool. We can like detect more polyps, and he like puts his hands up. He's like, oh my God, detect more polyps. I'm trying to detect less polyps. I'm detecting too many polyps. And so again, it sort of depends where you're coming from, what your kind of your goals are. I think in academia we think, oh yeah, detecting more, taking out more polyps, it always, we're doing the right thing for the patient. But you're right, in clinical practice, people are kind of fearful of something that's going to slow them down. and, even these assistive tools that are going to slow down their withdrawal. I think a lot of endoscopists where, their main goal is to, get those 11 procedures done in a half day and just, get out on time. I'm sure there's going to be pushback, and those aren't going to be the endoscopists that adopt this first. But having said that, I think a lot of us feel that quality is so important, and I think we have such a variation in quality of exam from one endoscopist to another, from one institution to another, from the ASC versus the university hospital. So maybe from an administrative standpoint, if there was something that could sort of bring everyone up to a sort of a requisite level, I think that would be good. That would be good for patients, because at the end of the day, really the reason why we're there, putting that scope in them with this invasive procedure, is to do a good job.
Okay, great, Dr. Sam. Thanks so much for taking the time out of your busy day to help us with this and being able to share all the information here today.
Mike, I'll be sending you the bill for my $30 meal that I'm about to right now.
Great, whatever you want, all the McDonald's. Yeah, no problem.
That's a lot of Chipotle coming to my house right now.
Right. Great.
All
Well,
right,
thanks everybody. Yeah.
Great seeing you, everyone. Yeah, thanks so much.